Hi there, Dr. Terry Shaneyfelt for UAB Department of Medicine. In this video, I'm going to discuss the perioperative management of patients with hyperthyroidism undergoing non-thyroidal surgery. So hyperthyroidism can affect the perioperative outcomes in a variety of ways. And the main things we need to think about is the effects on the cardiac system. So certainly cardiac output is increased in patients with hyperthyroidism, and there's increased cardiac contractility as there widened pulse pressure. Certainly these patients can have tachycardia, and atrial fibrillation is often caused by hyperthyroidism, and they have increased oxygen consumption and carbon dioxide production. There's other effects of hyperthyroidism, but these are main ones we need to think about in the perioperative setting. There are no studies on the risk of hyperthyroidism on non-thyroidal surgery. Most of the information that we have in this area comes from patients undergoing thyroid surgery. And it's important to remember that surgery can precipitate thyroid storm in a patient with newly diagnosed or poorly controlled hyperthyroidism. And we really need to keep a vigilant eye out for this, and it usually occurs during surgery within the first 18 hours of surgery, and it's manifest as tachycardia, heart failure, very high temperatures, altered sensorium, and patients can have nausea, vomiting, diarrhea, and hepatic failure. So it's important to keep an eye out for this and not think about just infection in the postoperative period if a patient develops fever or altered mental status, but to keep an eye out for thyroid storm because it does have a very high mortality associated with it. So how do we manage patients with hyperthyroidism? Well, in patients with subclinical hyperthyroidism, most of these patients can go to surgery, whether it be urgent surgery or elective surgery. They're not going to really have too bad of any clinical outcomes, and you could consider beta blockade in this group. For the rest, those who have mild to moderate or severe hyperthyroidism, if surgery is elective, you really need to postpone it until these patients are euthyroid. Now, in patients with mild to moderate hyperthyroidism, you want to give them beta blockers and thionamides. And we'll talk more about how to do this on the next slide. But in severe hyperthyroidism, you have to take this a step further. Number one, I think you really should consult endocrinology because this isn't something the typical hospitalist or general internist doing perioperative medicine is going to encounter very often. But we're going to use beta blockers and thionamides. And we also need to give iodine in this setting. And it's important to do it after you give these patients their thionamide. And if patients can't tolerate any of these medications, some will actually need an urgent thyroidectomy, but this should be fairly rare occurrence. And it's important to note, and I'll mention this again on the next slide, iodine, that you really need to be cautious if a patient has or is suspected to have a toxic nodular goiter because iodine can actually precipitate hyperthyroidism. So what about beta blockers? So beta blockers are really the mainstay of therapy for a hyperthyroid patient. It really is very good at controlling the clinical manifestations of hyperthyroidism. If for some reason patients are unable to tolerate beta blockers, you can use calcium channel blockers in this setting. And longer acting agents are preferred. So once a day atenolol is preferred over shorter acting agents. And you want to dose your drug to achieve a target heart rate less than 80 beats per minute. You want to continue your beta blockers until thyroid disease is under control. So you may have to be on them for several weeks or even months. Thionamides actually block the synthesis of thyroid hormones, so they're going to be really the cure, if you will, of hyperthyroidism. But they do take some time to kick in, can take weeks to a month or two before they actually have maximal effect. And in the surgical setting, methimazole is preferred over PTU because of its longer half-life. It can be dosed once a day. But remember, PTU is preferred during pregnancy, and it also can reduce peripheral conversion of T3 to T4. So it does have its use, but in this setting, methimazole is preferred. So you can remember the effects of PTU being used during pregnancy and peripheral conversion because of the P in the beginning, and that's how I remembered. I used this P to remember the other effects of PTU. And the nice thing is these drugs, if patients can't tolerate PO, can actually be given rectally. If you talk with the pharmacist, they can get a preparation that can be given rectally. And finally, iodine for those patients with severe hyperthyroidism. It does block T4 and T3 release from the thyroid gland. But remember, as I mentioned previously, if patients have toxic nodular goiter, you don't want to give iodine because it can actually precipitate hyperthyroidism. Now, in Graves' disease, it's totally fine. You can use iodine. It doesn't seem to precipitate the hyperthyroidism. So I think it's important to keep in mind that patients with poorly controlled or severe hyperthyroidism can develop thyroid storm. Keep a vigilant eye for this in the intraoperative and immediate postoperative period. I think it's also very prudent to get endocrinologists involved in taking care of patients who have anything beyond really mild hyperthyroidism in the surgical setting. They're going to be someone who deals with this a lot more commonly than many of us do in helping make sure these patients have a good outcome.